My name is Irina Savelieva. I'm a cardiologist at St. George's Hospital. I've been involved in works in atrial fibrillation for many years. I've been part of the task force committee for the guidelines in 2010 and 12 and coming guidelines in 2016. And I've done many trials in atrial fibrillation. It's my area of interest. How to identify patients at high risk of stroke. That's obviously the question that all physicians who face patients with atrial fibrillation for the first time should ask themselves. That's a very important component of management of atrial fibrillation. And of course, there is a CHADS VASC score. This is a very good scheme that has been adopted by many regulatory authorities and guidelines, which is pretty simple. It incorporates major risk factors which are easily identifiable during your first interview with your patient, and it includes congestive heart failure, left ventricular dysfunction, age, hypertension, diabetes, previous stroke, advanced age. Well, if you consider someone age over 75 nowadays as advanced, so that's your answer, and female gender. The problem with the CHADS VASC score is that we don't have very concrete data in patients with the CHADS VASC score 1, for example, and we don't know exactly what the weight of separate, isolated risk factors are in a patient with a CHADS VASC score of 1. And there were reports that probably these patients are not necessarily at that very high risk of stroke when anticoagulation is warranted. The EC guidelines, however, do support anticoagulation in these patients, and I think that physicians should follow these guidelines. On the other hand, an important thing is that patients with a CHADS VASC score of 0 are not entirely risk of stroke-free. Completely, strokes do happen in otherwise healthy person with atrial fibrillation, with low atrial fibrillation, if you will. And this is a particular problem for us physicians, because obviously for such a patient, stroke is a absolutely devastating consequence of untreated atrial fibrillation that we could have prevented in this case. And we're trying to develop new markers, for example, some biomarkers such as BNP, brain natriuretic peptide, troponin, some coagulation parameters, in order to assist to tune better risk stratification in this particular patient population. Some imaging techniques, for example, MRI of the atria may indicate that certain morphologies of left atrial appendage, for example, may predispose to higher risk of stroke. The extent of left atrial fibrosis also has been shown to be associated with increased risk of stroke. So that's risk stratification is ongoing, it's a moving issue. But for the time being, for the clinician, when you first face your patient with atrial fibrillation, do CHADS VASC score, and this would help you will guide your management in terms of oral anticoagulation. Bleeding as a result of oral anticoagulation is, of course, a dreadful consequence of that probably was imposed on the patient by us physicians, and therefore numerous schemes have been developed in order to predict such a tragic consequence of treatment with oral anticoagulants. We advocate the use of Hasblad. That's a very simple one to calculate, and again it does include factors that are easily identifiable, and most importantly, they are easily, or to some extent, they are modifiable at the same time, not only identifiable nor modifiable. For example, it helps to highlight patients with poorly controlled hypertension, which predisposes to higher risk of intracranial bleeding, for example, or patients who are receiving concomitant medications that may potentiate the adverse effects of oral anticoagulants, for example, on gastrointestinal tract, etc. So we physicians, by calculating this risk score as blood, we can identify factors that we can change, and therefore we can reduce our patient's risk of bleeding. But at the end of the day, it is a very fine balance between the risk and between benefit. And therefore, of course, here we have to exercise an individual approach to the patient. Of course, again, here we also have some new developments. For example, there is a very interesting observation that finding of microbleeds on the MRI of the brains may actually predict the subsequent hemorrhagic stroke, or even ischemic stroke, and this would help to risk stratify patients in terms of anticoagulation. Of course, it is mainly a research tool, as well as the previous imaging of the left atrium that we discussed, but it's a research tool today. Tomorrow, it is part of risk stratification in terms of bleeding. NOACs and warfarin, that's a dilemma. And NOACs, that's the acronym from new oral anticoagulants. However, I think that these drugs are not that entirely new, and NOACs now stand for non-vitamin K oral anticoagulants, not new or novel. So the development of these agents really revolutionized treatment of patients with atrial fibrillation, because yes, up until 2010, 2011, warfarin was the gold standard in the majority of patients, and we know that warfarin, even if it is well managed, still does not provide 100% protection against stroke. And what does it mean well managed? It means that time and the therapeutic range should be at least 70% or higher. And this is not achievable in many countries in real practice. And actually, real TTR ranges somewhat between 20, maybe 50, 60% in the majority countries across the world, even in centers of excellence. So this is a drug which is difficult to manage. However, the non-vitamin K oral anticoagulants offer an advantage of a more predictable, more rapid response, more rapid effect, and reasonable safety compared with warfarin. Actually, as a class, these agents were much more effective than warfarin in terms of preventing systemic embolism or stroke. As a class, of course, with some differences between the drugs, and as a class, these drugs were associated with better survival, lower mortality, which is quite a great achievement compared with the so-called gold standard warfarin. So I think that it's no-brainer, in fact, if you have a patient with no contraindications to anticoagulation, who is in need of stroke prevention, who has obviously no contraindications to non-vitamin K oral anticoagulants, that's probably be your choice. How you select between these agents, it depends on the individual patient pattern, and I will not go into this detail at this stage. However, warfarin will remain and will be used in our practice, and for example, patients with valvular atrial fibrillation, specifically patients with mechanical prosthetic valves, and patients with rheumatic heart disease, which still exists in certain parts of the world, they will have no option but to go on warfarin. Of course, maybe future studies in such patients with NOACs will show different results, but for the time being, warfarin is the only agent that we can prescribe to these patients. Now, there are obviously some gray areas, such as treating patients with acute coronary syndrome and atrial fibrillation for the time being, until the results of large randomized clinical trials, which are ongoing, are available. Warfarin and antiplatelet therapy is what the guidelines recommend for these patients, at least for the first year after their index event. Then, of course, we have a subset of young patients who would require warfarin, and in young patients, I mean under age 18 or 20, these so-called new drugs or NOACs, they haven't been tested. Therefore, for the time being, we are limited to warfarin when it comes to treatment of this patient's population. In pregnancy, when it is safe to give anticoagulation with warfarin, then NOACs haven't been studied, so that's your another option. And some subsets such as hypertrophic cardiomyopathy, etc. However, having said that, there are a number of studies with effectively all NOACs that are addressing these gray areas that simply could not be addressed in large randomized clinical trials such as Rely, Rocket, and Aristotle. There's a number of these studies have been instigated, and we will have the results how to manage patients in this particular scenario. But I think that at the end of the day, we are moving from warfarin to NOACs, and I think this is the right way, the right direction.